Okay, so now we have Dan Hanley, who is going to tell us about the future of neurocritical care. And I think this is a special lecture. Dan, I think, has collaborated with Chip Moses to come up with some thoughts and ideas as to what the future of our specialty looks like. Dan?
Thank you. There we go. All right. Wendy, that was great, and I think you have a permanent job now for as long as you want to hold it. I'm sorry that Chip Moses couldn't be here. He did, as we heard earlier, have a critical role in implementing the ideas that you heard about. And I think he's the person who really had the mission to answer Jose's question of, what special arm twisting, et cetera, did it need? And he gave the assurances that the group that you've heard about, and I think everybody else who has contributed to these 40 years committed to. And that trust, I think, was very important and is an important ingredient in any venture. So I listened. He has a nice recording about the series of events that occurred, and I think it'll be part of how this is remembered and be available to people. And I suggest that you listen to it. I think everybody knows what answer I'm going to give to the path forward, and it's really a pretty simple answer. Follow the original ideas of Johns Hopkins in his endowment, which I thought was 5 million, not 7. And that is combining patient care, education, and research. And my bias, as I showed you on my disclosure slides, is that the research part is really important. And I think if we keep the other principles, the research will inform where we need to go. I think the other thing that came out in the question and answer period is that although the patient is our critical focus, it's, I think Cecil said it, but several others did as well. People are really the instrument of doing something, and the purposeful and well-educated professional is the real instrument of success. But that well-educated, purposeful professional also doesn't have all the answers, which is an important part of being professional, to admit you don't have the answers. That person, those persons, and it is a team, need information, and that information comes from research. This is where we started as a team around those principles. And I'm using brain injury as a generic description of any problem where the brain is either at risk or is having a problem. And I think as part of Ski's leadership, the right-hand side of this slide, thinking about the context of the patient, the family, their friends and their community is very helpful in coming to a solution for any one problem that comes to you. And in the NCCU, there are, what is it now, 18 problems a day that individual people bring, and then there are many more sub-problems. And this was my answer to you, Jose, about what to learn, what have I learned, and what might I have done sooner. And I'll show you briefly a few vignettes about why one of SKI's important emphases, the patient and caring for the patient, are important to integrate into the research you do and the data you collect. So the NCCU is a place for intensive care services to support patients with neurologic disorders. And everybody understands how we came to that, but it's a place for patient care, and that's really got two components to it. Not to be pedantic, caring about your professionalism and the needs of that patient, and then just looking at the patient themselves and what the results are. Gail Biba's gonna talk about this, and you'll be able to see it. This is a tree of life of all the nurses that came and grew out of the initial effort of SKI and Cecil and myself. But this is a tree that SKI nurtured, and Gail will talk about it tonight. It's quite an accomplishment. There actually aren't 112. There are somewhere around 220 leaves on that tree. So a brief history. In planning this meeting, at one point, Cecil made this quote, which I think you've heard. In 1980, when we began to plan it, we didn't have a textbook to know what to do. We had some kinds of physician knowledge base on the left, and the beginning of an organization around critical care medicine that evolved in the 80s. And we had some curriculum that came in large part from Mark Rogers and Dick Traitsman, two names we haven't heard yet, who liked physiology, which Betsy still likes today, and who began to teach many of us, John, Mark, Jeff Kirsch, Jeff Ling, and many people who aren't here, about the benefits of looking carefully at physiology and understanding what's happening in each of our individual patients. The other thing that we didn't have in that idealized textbook that we would have liked was a knowledge of the natural history of the brain diseases as we were seeing them right in the acute setting. And we didn't have much knowledge about understanding which problems we could reverse and which problems we couldn't. And that works for the brain, the spinal cord, muscles, and nerves. And we've already heard alluded a very nice story about Guillain-Barré. So there was a lot of information and data to acquire. I think, to answer the question, and I've already told you the answer, the NCCU future is to make patient care more predictable, and that came out in the discussion as well. Dull and nothing happening in the end can be very good, or getting a sick patient to that place where it's dull and nothing is happening, and the patient can resolve their illness, I think, is a very important goal. And it needs trials in all shapes and all sizes to collect that data. And there are lots of different kinds of trials. We're not going to talk about them today, but in our data-driven society, the opportunity to do those trials is just beginning, despite the fact that there have been a lot that have already been done that are the basis of the work that's now going on in the NCCU. If you have that patient focus, which I said I thought would be, we might have done even more had we really understood the importance of it. I've stolen this from Lourdes Carhuapoma, another nurse researcher who is a newly minted PhD, from her thesis. And these 4 questions we implicitly knew were in the mind of almost all of our patients, and probably in this order for most people. Not everybody's the same. But these are the important unknowns for the patient that we have to confront. And I'll show you a little bit more about how Lourdes has organized her thoughts around how we talk to patients and families a little later. But keep that in mind. So I think data and trials and strategies, whether it's for research coming from animal models, which a lot of us slaved over in the anesthesia, neurocritical care research labs, or whether it's coming directly from patient care, which we have much more access to that, you want to call it big data, today, or whether it's informing our educational efforts to share with other people what we know. The best strategy is to have data, and the best data comes from trials where there's causal inference, where there's an intervention that's given to half of the patients but not to the other half. So here's some data, and it comes from an interest in brain hemorrhage, which many of us in the room share, and this comes from our MISTY-3 trial where, and I think I agree with Gail, with fear and milieu rounds, I will say ski is wrong. We and she have influenced people all over the world. This data comes from 60 neuro ICUs across the world that contributed to a trial to understand surgery and intracranial hemorrhage. So this is a receiver-operator curve, and it tells us our ability to predict. And that little number down here on the bottom is the area under the blue line, and it's 80% of this square, with 20% being unknown factors that control what we're trying to predict, which is the y-axis. Is the patient going to get better enough to be a Rankin scale 0, 1, 2, or 3? All of those allow you to be at home and to be caring for yourself. So come back for a minute to the question that all of the patients bring to us in the unit. Having that data is important, and also having the courage to say, you know, what I know works for 4 out of 5 patients, but not for the 5th, and I don't know which one you are, but we're going to do our best to put you on the underside of that line in the 80%. is a very important thing to learn. And in the lower right, what's called the severity index, which are the factors that control where that blue line is, the age of the patient, their GCS at the time they present, the location of the bleed, how big it was in the brain and how big it was in the ventricle, and what some of their medical comorbidities are. Those have turned out, by testing and trials multiple times, to be really strong predictors. But they're not predicting everybody. There's that 20% they're not predicting. And that's why we still need more data and more research. This is taken from the Pharmaceutical Society's defense of pharma and why the costs of drugs are high. We can argue about their argument and the quality of their data. But what's interesting here is you start with a large number of opportunities, and it takes multiple years to get to a trial that proves something is beneficial. And that's been clear in the work that's gone on for the last 50 years. So research and clinical trials are long and slow. We're fortunate that in the NCCU, we now have the research that went on before us by Douglas Miller, Don Becker, and many others. And we have the 40 years of things that we and our peers, even our peers at UMass Worcester, where we have a new member coming into the neurocritical care area, have done as well. So there's lots that has happened. This is the other mood-altering view of research and clinical trials, and that's the roadblock. And you can stick any name you want on that big boulder, whether it's blame the IRB, blame the hospital administration, maybe even blame yourself a little bit. But there are barriers, which is why it's slow. But the gains are worth it. And having legitimate expectations about the gains are going to be incremental, I think, is important. None of us are going to discover cold fusion, but the things we do discover will help us better answer those questions for patients. So here's a tree of all the clinical trials, Jose, and I may have missed some, but there's more than 50 that have come out of the efforts of everybody in this room. There are branches in cerebral ischemia that John contributed to. There are branches in metabolism that Mark contributed to. There are branches in cerebral ischemia that Alex Razumovsky contributed to. There's an infection branch. There's Guillaume Barret. There's subarachnoid hemorrhage that many people have contributed to and is now your focus, both Jose and Betsy. The green leaves are the trials that could be considered positive, that have either a primary or, in the case of two of the ones I've done, Misty and Clear, it's the main secondary mortality that was positive. So we learn from our mistakes. The majority of our trials aren't positive, but that doesn't mean we haven't gathered meaningful information for our patients. Trials use causal inference, and that's why they're important. And causal inference is simple. We heard Don Long quote St. Augustine, and it's pretty simple. We learned it probably in middle school. If X is provided, then Y occurs. And if you know that, you know what you should do, and sometimes what you shouldn't do. And sometimes a lot of the things that you shouldn't do are in those leaves that weren't green on that tree. What I learned in the NCCU, walked in there thinking brain physiology was the answer to everything. And it's necessary, and you have to know that neuro exam, which we heard early on was the reason that brought Ski to the NCCU and to Hopkins. But it's not sufficient. You need a meaningful endpoint for those patients and families, which is a longer-term endpoint. And we've been lucky enough, as that tree grew, to be able to get more of those long-term endpoints. And if I want to encourage everybody in the audience who is the future here, it's to take your big idea about the NCCU, but also look for its delayed impact on people. And understanding the patient perspective is central to determining participant value, and that's central to the likelihood of making a change in practice. This is some data from our MISTY-3 trial. Guyan Yanokian, a statistician, has been very interested in the recovery trajectory. So is Wendy, so is Vishank Shah. And you can see on the left are the people who are more mildly injured by their ICH, and they have a taller or bigger recovery, and it occurs fast and then more slowly, but it takes a year. And on the right, people with a bigger injury don't have as big a recovery, but they have a recovery, and it also continues for a year. And maybe the 180 to 365 slopes are a little bit different. You have to understand both the timing of the recovery and the amount of recovery if you as a professional are going to help the patient and the family in your bed at the beginning of their illness. Here are the non-physical scores, and this is a very important point. I'm going to flip back to the physical scores. They're lower. The non-physical scores are higher, both for the mildly injured or less severely injured and the severely injured. Non-physical things, non-physical capabilities become more and more important to the individual who has the disease as they recover, and you can see that here. So if we only value what we do by the physical measures that our patient can perform, we're missing an important perspective that the patient has, and we're not advocating for that perspective. And that's one of the things that research has taught Lourdes and Wendy and many others in this room. This is an evaluation of the same data. And what's nice about big trials, if you collect data and you collect it in a robust way, you can have lots of secondary things to analyze. Now, in one trial, you get to answer one question, but I think I've already said there are many questions you have to answer, and the other data can go to the things you didn't answer that may help you with the next trial. This is part of the PhD thesis of a woman named Radhika Advani, who, like Guyan Yanokian, is a statistician who, because of the NCCU, is devoting her professional life to brain injury. And these are paired bars at 3 months, 6 months, and 12 months of what the Rankin score is of the patients who had brain hemorrhage. And you can see the second of each group is the group that has more depression and anxiety or reports more, and they seem to do worse. And this is a variable that we haven't looked at enough. But by having the data from the trial, we know where to look now. Here's something that Vishank Shah did with that same data. And it's this question, which we go right back to Lourdes's questions, what's going to happen to me? And when I entered the NCCU, I thought we could tell in the first few days or first few weeks how most people were going to do. And I still have a professional sense that I might be able to guess that. But these are the people who are recovering from brain hemorrhage, who at 30 days have a Rankin score of 4 or 5 and are considered dependent, okay? And we have, in this disease and many others, had family conferences where we try to help people make decisions about how much care to render and whether to continue to render it. But if you look, on the left are the Rankin 4s, and on the right are the Rankin 5s. Both of them improve remarkably over a year. So the time frame that was our basic assumptions may not be right. And research and data inform that. And I know I certainly do, I don't do family conferences in the NCCU anymore, but I do family conferences. And I use the newer data because it helps inform us as to how we can be better advocates and stewards for the wishes of our patients. So the shank, these are those same receiver-operator curves. The red is those baseline factors that a patient brings on the day of their illness to the NCCU. And the green are some factors that relate to patient care and how we achieve some clinical goals, and also to complications that we know at 30 days that actually allow us to take that prediction from 8 out of 10 to 9 out of 10. And that difference between the blue and the red, on the left for clear, in the middle for misty, and then the combined, which gives us closer to 1,000 patients, tells us that what we already talked about today, we actually know that we do something in the NCCU, and that it is good and it is valuable. But we have to continue to prove that to everybody who perhaps doesn't think that what we do is as important as what they would like to do in another area. Talking to the patients. I'm sorry, I didn't get to fix the banner on this one. But I made this comment earlier, paying attention to the patient's needs. Why not actually ask, let's go back here for a second. Whoops. The Rankin score is determined by a medical professional. But asking the patient how they feel about things, and I showed you that difference. The Rankin score has a pretty good bias towards motor performance and how much motor performance you can have. Patients reorient their goals towards personal and communication and social goals where they often don't need as much motor performance. And understanding that difference is really important. One way to do it, the simplest, quickest way, is the Euroqual. You can spend 5 to 10 minutes on it, and it's got 5 dimensions, the Euroqual 5D. Or you can also use the visual analog scale, which we've used well in pain, and 100 being, I feel, the best I've ever felt. Most of us don't say that every day when we get up. And I'll show you some more data on that in a second. And 0 is the worst. And it's quick and easy. So we did that on 500 patients in CLEAR and MISTY in the clinical trial. That little X is where people like me are. Americans between the age of 45 and 75. We average about, I'm okay. This is misty on the left and clear on the right, each one 500 patients from a clinical trial. The columns are the Rankin scale, 0 being I'm the best I can be, not having any problems. 1, I have a minor problem, but it doesn't interfere with any activity. 2, I have a minor problem and it interferes with some activities. 3, I can't do all the activities, but I can be independent. 4, I can't be independent, I need help with some daily activities. And 5, I need complete help. The y-axis is that Euroqual, 0 to 100. And you can see in our patients at 1 year, even what we would consider on day 1, if we use ourselves as a comparator, an unacceptable outcome. I need help with activities. I need complete help with activities. There are a wide range of responses that patients have to their situation at a year. And many of them are what we would call happy to be alive. And understanding that variation in responses, I think is important to how we talk to patients and families about their outcomes. This is from Lourdes' thesis, and you can see that same visual analog scale is on the y-axis. You can see as people go through acute care, sometimes a nursing home, long-term care, rehab, and then get home, their ability to have personal happiness, to be at peace with their situation, increases greatly, and it approaches the norm for age without any disease at all. And that's powerful information that 40 years we couldn't bring to bear on the discussions we had with patients. So I argue we have the right model from Johns Hopkins, research, training, and patient care. If we're going to move things forward, we need to ask questions about what we're doing and how we can improve it, and gathering data from all places. Robert's going to talk to us about big data that comes from physiology and from healthcare, really important, and gathering data that has causal inference, if X then Y, are really important to the future of neurocritical care. So what did we learn just in this little data extraction exercise from MISTY? Small ICHs recover faster than big, and we have some definitions. Return to baseline function isn't as likely after big ICHs, but return to social function can occur and does happen even in the bigger ones. The initial impairment score is important to predict recovery. Medical comorbidities in that original prediction score are important, and so taking care of them and not letting the heart attack happen, not letting other renal and pulmonary things happen is important. Patient-family decision-making benefits from data, and this comes from Lourdes' work, from Wendy's, from Vishank's, from Radhika's, from Guyan Yanokian. And I think understanding and identifying mood and anxiety earlier on, since they're mitigatable, is something we need to put more effort into in our neurocritical care unit. I'd like to give credit to a number of people. Somebody I haven't mentioned who's sitting in the back is Nicole McBee, who was the second employee of Brain Injury Outcomes and who managed the acquisition of all of this data and managed much of the analysis. And you can see the other names. 4 decades has made a difference. There are a lot of accomplishments. Nobody questions the need for an NCCU anymore. That's pretty good. We've shown organized care in the NCCU improves patient recovery. We have healthcare delivery data on it. Mark Mirsky left the NCCU, went to Queen's Hospital with Felissa Caserta, started an NCCU, and they have a nice before-after comparison. And it's a 10 or 20% difference, just like you can see from Vishank Shah's analysis of predicting who's going to get better and what happens in those initial 30 days in the ICU. There's a whole list of things under the third bullet where we now have effective treatments and they're integrated into NCCU care. And we understand how to train an effective team of healthcare workers. And their work is occurring daily across the world, which I think is an example of dissemination that SKI wanted. I think it actually has occurred. The trials, if nothing else, show that. There's a lot of work in progress. I listed it on the right. I'm not going to read to you. One of the things that I think we need to do more of is look at long-term outcomes in a long-term outcome care clinic that gives us the benefit of seeing the patient at the beginning, in the middle, assessing the patient needs, and giving ourselves feedback on what we did well and what we didn't do as well. You're going to hear the bullet above it, predictive analytics. We're going to hear a lot about that from Robert. I'm not going to steal his show. But all of it should inform what we do about our basic business, which is patient care. If you want to read something about clinical trials and how they work, that's pretty good. Thank you very much.